So good morning, afternoon, and good evening to everyone. It's a great pleasure to welcome you to this webinar hosted by Health Systems Global on Community Health Workers, the Gender Agenda. This is a webinar, it's a wonderful collaboration with the Health Systems Global Thematic Working Group on Community Health Workers that's teamed up with RINGS, which is Research in Gender and Ethics in Health Systems, which is a collaboration with partners across the world, as well as with the Reach Out Consortium. We're really excited. There's been a lot of attention to community health workers, but we're really excited to talk more about what are the gender issues. And I know Health Systems Global had a webinar, I think a year ago, with the thematic working group looking at the evidence base for community health workers in general, and we started raising questions about what are the gender dynamics. So it's wonderful to have this webinar that focuses particularly on this. It's going to have a cross-cutting presentation by Sally Theobald, as well as in-depth country presentations by colleagues in the DRC and from Gaza. Before I introduce the participants, I'd like to just go over a few pointers about the webinar. We have all the participants. It's fantastic. We've had almost over 200 people registered. You're all in mute mode, but we're really looking forward to having a question and answer period after the presentations. So we will, you can submit your questions. There's in the webinar right side column, there's a box for questions. And so we really look forward to your questions. You can submit them at any time and we'll be looking through them. We're going to, if there are quick questions for clarification, I'll ask them to the panelists. Otherwise, we'd like to have more substantive questions. We'd like to save them to the end so that we can really have a dialogue with our excellent panelists. We'd like to also, we will keep this webinar to an hour. We will finish a little bit earlier so that there is an evaluation. So even though once the webinar is over, we asked you to stay online. It'll only take you 2 to 3 minutes, but I think it would be fantastic for us to get your feedback, not just through your questions, but also your feedback through the evaluation, which will come on once the webinar closes, and it's just a few minutes. You can answer through the WebEx connection. I'd like to, before I go over the panelists, this activity, this collaboration hosted by the Thematic Working Group, Health Systems Global, and RINGS with other partners is part of a whole month that we're looking forward to in March. March 8th is the International Women's Day, and Health Systems Global has really been fantastic in working with us to schedule a whole month of activities to look at gender issues in health systems. And we hope that this spikes a lot of interest. We, just as a reminder, the deadline for abstracts, for individual abstracts for the Vancouver conference is 20th March. So I hope this sparks a lot of interest and follow-up, and we hope there'll be a lot of submissions from all of you on gender and community health workers, but also in gender and health systems more broadly. So with that overarching overview, let me go to the next slide and introduce each one of the panelists. So myself, I'm Asha George. I'm a professor here at the Johns Hopkins School of Public Health, and it's wonderful for me to chair this because I've worked with some of these individuals. Sally Theobald from the Liverpool School of Tropical Medicine in the UK, in really trying to highlight gender issues. And we're really excited to have Amuda Baba from EPASC, the Democratic Republic of Congo, to really share with us what are the experience coming from the DRC, looking at situations of conflict, what are the perspectives and dynamics in gender and community health workers there, as well as from Hana Rabadi from World Vision in Jerusalem, West Bank, Gaza. And she'll be sharing some of her experiences reflected to gender dynamics there and how transformative it has been to take on a gender perspective. So Sally will be giving an overview presentation based on a literature review that frames gender issues across the literature, and then we have 2 country case studies that ground what she's saying in specific examples. So I don't want to take more time. Let me hand over to Sally for now.
Thank you very much, Asha. So next slide, please. So as Asha has outlined, I'll be giving an overview presentation on the gender agenda. So next slide, please. And I would like to start by positioning ourselves within the global landscape. And with the launch of the Sustainable Development Goals, we've seen an increasing focus on universal health coverage. And target 3.8 of the Sustainable Development Goal around good health is all around achieving universal health coverage. And this has brought community health workers back into the spotlight as a key cadre that are critical to the journey towards universal health coverage. We've also seen a lot of discussion around SDG 5 on gender equality, and Richard Horton, writing in the Lancet recently, has said that it's a potential danger to those of us in health if we neglect gender equality. So what we're doing today is pulling together the debates around community health workers and gender equality. Next slide, please. So community health workers or close to community providers, like all cadres of health workers, their experiences are shaped by gender roles and relations, and there are evidence gaps in understanding better how gender and power shape the experience of community health workers and their ability to provide close to community services within different contexts. And context matters. Context matters in terms of the ways in which community health worker programs are designed and are implemented. And context also matters in terms of how gender roles and relations are experienced across and through time. And there's been particularly little discussion on community health workers and gender within fragile and conflict-affected settings. So it's great that we're going to hear more about that today. So next slide, please. So as Asha said, I'm linked to Reach Out, which is a consortium of partners working through context analysis and through quality improvement cycles to develop strategies to improve the equity, efficiency and quality of close to community providers. And we work on that in Liverpool School of Tropical Medicine in collaboration with colleagues in Malawi, Mozambique, Kenya, Ethiopia, Bangladesh and Indonesia, and with KIT in Amsterdam. And we're looking to develop lessons for addressing gender inequities and power in policy and practice of CTC provision. Next slide, please. So just to show you our Reach Out website, you can see the webinar here is advertised there under news. So please do visit it in terms of looking at the resources and blogs and papers that we've been generating. Next slide, please. And I also wanted to alert everyone to a new, exciting, open access special supplement of human resources for health on supporting and strengthening the role of close to community providers for health systems development that has been organized and managed through the Health Systems Global Community Health Worker thematic working group. There's 14 papers from a variety of different contexts, and we are currently writing the editorial to synthesize the learning from those different papers. So it's been a great opportunity to also look and understand more about how gender, equity and power has been discussed in those papers. So do please have a look at those. Next slide, please. So who are CTC providers? Globally, It is estimated that 70% of CTC providers are female, so a largely female cadre, but this varies across contexts. So in countries such as Ethiopia, health extension workers who form the backbone of the health extension program are all female by policy. In other contexts, it's mixed. There's sometimes a formal employed cadre remunerated and integral to the health system, and other times can be volunteers who are brought on board for more ad hoc activities. But what's central to all of these community health workers is that they come from the communities they serve. They often live within those communities, and they have the opportunity to understand the ways in which the social determinants of health play out: poverty, malnutrition, violence, unemployment, and what that means in terms of household dynamics, in terms of vulnerability to ill health, and in terms of access to healthcare. Next slide, please. So what does it mean at an individual level, the experience of being a community health worker, whether it is an empowering experience or not? We're going to hear more about that from Gaza and the West Bank. But gender roles and relations shape the deployment of CTC providers at the individual level. And as we've said, in Ethiopia, by policy, the health extension workers are all female. Community health workers in Kenya are mostly female. In Kenya and Malawi, the attrition of male volunteers in both urban and rural areas has been attributed to the gender role of men as breadwinners. And certainly what we see from the literature and from our analysis is that when those roles are voluntary, they are more likely to be female. We've also seen from our analysis and from the literature the challenges many female community health workers feel about the pressure of competing demands, of juggling multiple balls, of delivering their work alongside community and household responsibilities, alongside agriculture, and that spousal support is seen in many contexts as critical to being able to deliver that role. Mobility and accessibility is an issue. In Afghanistan, women have restricted mobility, which has made traveling to other villages difficult. And this has had a knock-on effect on career progression, as limited mobility and lower education status has meant that women were not found in the more higher positions of community health workers. Next slide, please. So what does this mean in terms of the community level? And it's interesting in the literature around community health workers, they are conceptualized in two different ways. First, as a service extender, extending services to communities, and secondly, as a change agent, being an activist for change. And a lot of the literature and our analysis focuses, the literature and the research that we've done in Reach Out has shown that the role as service extenders is more clearly discussed, and again this is shaped by gender. So in Mozambique and Malawi, cultural and gendered norms formed a barrier to male apage or male health surveillance assistants visiting women in their homes. So gender and generation shape household decision-making with respect to health-seeking behaviour, and culturally embedded community health workers may be strategically placed to understand and address these, but are often restricted in bringing that learning into broader health systems, as well as having the space to discuss that in more detail. Safety is clearly an emerging issue, and the tragic recent gang rape and subsequent murder of Samwati, a village Asha in Uttar Pradesh, has clearly highlighted this. And the Human Rights and Health Watch Forum from Uttar Pradesh documented this together with the very strong, fast and swift response from Ashas who came together to get justice for Samwati and to push forward further demands for safety in their work. And Ashas are another all-female cadre. Next slide, please. So what does this mean at an institutional level? And the articles that we have in the special supplement all argue to different degrees within the discussion and the findings about the critical importance of robust, transparent, and responsive strategies from the health sector to support close to community providers to best realize their interface role between health systems and between communities. So having clear policies and processes that address the different needs of women and men in terms of payment, retention, selection, progression, and supervision is really important. And in our reach out analysis we did at the context analysis level, we found that supervision of community health workers was often absent, but when it was in place, it was more punitive or fault-finding rather than an empowering, supportive process. And so we're looking in our QI cycles about how to support that supervisory process so that it's an opportunity for problem solving, for reflection, and for support for community health workers who are juggling multiple balls and juggling the ways in which gender and power affects access to healthcare. So next slide, please. So this is just my final slide. So to say that close to community providers are embedded in communities and strategically placed to understand intra-household gender and power dynamics and strategically placed to understand the social determinants of health and how they play out, which is also coming up the agenda with the social development goals. We need further exploration about how to support community health workers to feed their perspectives into health system development and into priorities. And I think exciting potential here with mHealth to bring further data into the hands of community health workers, and some also exciting perspectives with monitoring and evaluation. And I've just returned from Nepal, where I was working with a herd group, and they are working with the Ministry of Health to have 360 degrees evaluation of district health teams, and that includes female community health volunteers in that process. So a specific way to engage and get the perspectives of community health volunteers into ongoing evaluation. So we need further work, we need further opportunities for intersectional reflexive analysis as well as in the literature. So I wanted to just give a broad overview and now very much look forward to the 2 country case studies. Thanks very much.
Thank you so much, Sally. I think there was a comment from the audience that followed up on Sally's comment on the Ethiopia program, and was just to concur that it's not just in Ethiopia, but there was Zaim Haq mentioned that there are large national programs that rely on women, whether it's lady health workers in Pakistan, Ashas in India, and also there was a comment that they form a large part of community health workers in Nepal are also primarily female. So we'll take in your comments as we go step by step, but we'll come back to a discussion about that. Let me go on to the presentation by Amuda. There was also a question on whether the slideshow will be available, and I think it will be posted on the Health Systems Global website. So over to Amuda. Thank you, Sally.
Thank you very much, Asha. Next slide again. Yeah, thank you very much. So I'm Amuda Baba, working with IPASC. IPASC is Pan-African Institute of Community Health based in northeastern DR Congo. So I'm going to talk about gendered experiences of community health workers in a fragile context of rural DR Congo. This is resilience and mobility. Next slide, please. What is the human resource issues in the context of DRC? But human resources in health, they are much more concentrated in urban areas, about 70%, and this situation exacerbates during war and conflicts. So there are still challenges, and among the challenges in the health system, we've got drug shortages, difficult working conditions, limited options for capacity building, not being able to transfer patients in serious cases. There is a problem related to equipment and also infrastructure, especially road infrastructure, which is very poor, limited supervision, and working in a context of extreme poverty. And the human resource for health attrition is in rural areas is really high. And rural populations normally self-medicate, either using traditional medicines or totally unprescribed medicine from local pharmacies because they cannot afford to pay for health services. Next, please. What are the characteristics in rural fragile DR Congo? We know that most of community health workers in rural DR Congo are elderly women. This is one of the facts. And there are very few people who are less than 30 years of age who work as community health workers, and those are especially male. They are very rare female at that age working as community health workers. The attrition of community health workers is high among young people because they just find the opportunity of starting working as a community health workers, but as soon as they find a paid opportunity, a job, they just stop as a voluntary community health workers. Next, please. Gender power and community health workers' experiences. What do we know about resilience and mobility in Congo? Normally, community health workers, they are really committed to work in order to provide support to their communities. As Sally said, they are really embedded in the context of their community. They accept to work in difficult circumstances. Their community's health is their main motivation. So whatever they do is for promotion of their communities. So these are some quotes which just back up that idea. There's one who said, we have accepted to take risks through service serving. We just make sure that every serious case is being taken care of. And that female said, when there is war, troubles, what I do is just avoiding move a lot. She invests herself in helping the community very close to her place, just to avoid problems with those fighting. And most of the problem which they avoid is especially rape, which is a very big issue during conflict in those settings. Next, please. During conflict and war, community health workers accept to risk their life when helping the community, as I stated before. And again, in that context, nurses often leave the health centers, leaving the community under the responsibility of community health workers, because community health workers just feel they cannot leave the community behind, the population, which are their fellows behind. So they have to be there for their well-being. And that's why they take responsibility also to transfer some serious cases to the referral hospital. And during conflicts, normally female community health workers who mostly are elderly, so they run high risk of being raped as they go about their duties at community level. Next, please. And this is just one of the quotes supporting that idea of the context within the rural DR Congo, as it was stated by community health workers, who is a male, during the focus group discussion we organized. So he just said, once during the recent war, there was a pregnant woman who was in labor. She was taken to traditional birth attendants as nurses were not there. She found that her condition was very serious. She could not manage. That lady was supposed to be transferred in the referral hospital. So we were asked to take her to the referral hospital, which was about 7 kilometers from where we were. And there were militia and soldiers all over. We were arrested by 3 different groups before we reached the hospital. We were 2 community health workers, the traditional birth attendants, and that woman. So we had to go back, expecting all the possible risk. So this is a kind of day-to-day issue in the conflict-affected settings related to the work of community health workers. Next, please. And again, those are codes which again show the vulnerability of women during the war period. So these are codes just to say how vulnerable they are, especially moving around and providing their services when the context is not, it's a conflict please. Gender of community health workers, and again, Sally mentioned it. There is a real problem. So women, for instance, find it easy to be open to share their problems with fellow women community health workers, because some sensitive issues they feel they are not ready to share it with men, and they are really open as to share those problems, especially with female community health workers. So this is again a key issue which is backed by some community cultural beliefs and beliefs in the area. Next, please. How are we doing to address those child issues? And we as a community health, Pan-African Institute of Community Health, what we normally do in this context is just to see in the local settings, in the local area, how we can identify potential candidates from unstable settings to be trained. So we take both male and female to have some basic training so that they could be able to deal with some community issues. And also, community workers are trained on the activities related to maternal health. And apart from maternal health, but they also cover different sectors of health. They play key roles in maternal health promotion in remote settings, as we say. And community workers, mother groups, they are very active in promoting women's health because they feel that women's health is a key to solve many problems, many health issues in the area. So the focus is much more in improving women's health. So despite challenges, there is a strong commitment to supporting communities because they feel it's their uncles, it's their aunties, it's their brothers, it's their grandparents, that they have to do something in order to protect, in order to help, in order to support those communities. Next, please. And this is a lady and a female community health workers trying to mobilize women on the importance of delivering a health facility in Aru, northeastern DR Congo. So they were very open, they shared a lot because they felt the person who was talking to them was someone who was culturally close to them. So they were very open to discuss some issues. Next, please. But for some basic, as you can tell, this is a male now community health workers. So we think he's trying again to raise awareness campaign on some local health problems, to get what are the local understandings of the local health problems. So as you can realize, he's talking to men, and there are very few females who are there, but talking to men, just trying to understand the issue. He's a male, so it was much easier for him to, as the topic was concerned, he could share it without any problems. But if it was a topic which was very sensitive to women, so there could be another female who was supposed to do it. Next, please. Yeah, thank you. This is again an expression of culture. These are pygmies, not far from our place. And one of them you cannot realize. One of them is a community health worker, just trying to pass on a health problem, but taking into account the way they share, the way they discuss on problems, not only health problems, but also problems affecting pygmies. This is the way they share the information. Thank you very much.
Thank you so much, Amuda. I think that after Sally's fantastic overview presentation, this gives us a really concrete example in the Democratic Republic of Congo, how important community health workers are, but particularly within that, how women are so committed in terms of preserving their commitment to community health, especially in the context of conflict-affected societies. And that's a reality, unfortunately, that's not just in the DRC, but worldwide, when as people we are watching the news, many areas in the Middle East, in many other regions, there's a fragility in terms of security issues. And I think it was so important to hear from you, not only how women are motivated to work in communities, but also to highlight the issue of security, which Sally also brought up has been an ongoing concern in the South Asian context, and to bring that back, particularly in situations of conflict, how important it is to build at the community level coping mechanisms to support women and communities. And also you brought out that it's not just women alone, that if we really want to transform societies, we really need to work in partnership with both male and female community health workers, and reaching out to men in the community is a critical part of the strategy. And therefore we'll be discussing more in the webinar about this pairing of community health workers. Before I pass over to Hannah, it's been great. There have been a lot of people writing in, concurring, showing examples of the nature of large-scale female community health worker programs. Sarah Parrish notes that the Alaska Community Health Aid Program is 85% female, and a colleague from Uganda, Trasius Mukama, notes that yes, in Uganda there are a lot of community health workers that are predominantly female at the village level, but once you go one level up to the parish level, when you look at leadership and coordination, that's primarily composed of men. So it's fantastic. So many people are actively listening and sending comments. We'll come back to more questions at the end of Hannah's presentation. I want to remind everyone that if you're on Twitter, to please remember to use the hashtag #HSGGender. So I think this is a great presentation that gives an overview of the context of DRC and how much community health workers put themselves on the line, significant risk to their personal security, but their commitment to community health is vital for really reaching out to improving health outcomes in very difficult circumstances. So let me pass over to Hannah, who's going to talk to us in a different part of the world, but really looking at what has been the lessons learned and experiences and outcomes of working with community health workers in Palestine. Over to you, Hannah. Thank you.
Thank you. Hello, everyone. What I will present is the community health workers in Palestine, the challenges and the achievements of introducing and implementing such a program in Palestine. Next slide, please. So we started this programming in 2008. We started it only in one community. We have identified 15 community health workers. We have trained, worked with them to check the visibility and to check the acceptance of such a program in Palestine. After that, year after year, we have increased the number of community health workers, and nowadays we are reaching to more than 150 communities all over West Bank and Gaza. And every year we add as well new community health workers on board, and we target more and more mothers. Every year around 2,000 mothers become part of our interventions, and they benefit from the activities and from the interventions delivered by the community health workers. Of course, this is like it wasn't a very smooth process. We have faced many challenges, many obstacles, and I will discuss this in the coming slides about the challenges that we faced in our community and how we overcome these challenges. The first challenge was at the beginning introducing something new to the community. It's not easy to introduce something new to the community, so at the beginning it wasn't accepted by most of the communities, even by the leaders at the communities. So this was a main challenge at the beginning, even with the community health workers themselves. At that time, we have discussed this with several people, introducing the idea. For them, it was something new. They said that we don't have the capacity, we may fail, although they showed huge interest, but they have so many concerns about the trust and about the acceptance of the communities to such kind of interventions. So at the beginning as well, there wasn't any support from the health system, as I mentioned, because it was a new approach and they were not sure about the capacity of those community health workers and what kind of services they will deliver and how they can support the system. So at the beginning, we faced many challenges that we try to overcome with time. Next slide, please. To overcome these challenges, first we said that we need to work closely with the steering committees at villages and introduce the ideas to them. We have met them all through different sensitization, orientation workshops, and the good thing is that they approved the idea and they said, okay, let's try and let's see the benefits of having community health workers serving the communities. After that, we have worked with them closely to identify those people who are trusted people, who are accepted people in the communities. And here I want to mention that in our context, all the community health workers are females. Because of the sensitivity, we are a very conservative communities. So for men to talk to women, it's not acceptable. That's why all of the community health workers were women, and still we are including more and more, but most of them are females. The second step, and I will talk on this step in more details, it's building the capacity of the community health workers. They have different backgrounds. Most of them, they were young women who didn't get the chance to complete their studies. So we worked on a capacity building plan to build their capacities so they will trust in themselves and they will have the proper knowledge to introduce and to support the communities with the things that they will learn. And based on this, we have as well created linkages with the health system, and I will talk in details how we made this linkage with the health system and the role of the community health workers now as part of the health system. Next slide, please. The capacity for the community health workers, it was mainly on maternal, child health and nutrition. They were introduced to practical and theoretical sessions through different trainings and capacity building events. They as well were trained on growth monitoring. They have been introduced to the social determinants of health, communication skills, and other related issues. The thing is that we trained them through the Ministry of Health. So we said in order to build a trusting relationship, we need to make and create these kind of linkages with the Ministry of Health and to create this trust, because at that time, the Ministry of Health, they had concerns about their capacity. So we said, okay, then you can train those community health workers, you can check on their capacity and to see how they can improve the services at the communities and how they can as well be part of the system and they can support the system in the villages. And what I would like to mention here is that most of our villages are in remote areas. They have poor access to health services, like it's only mobile clinic once a week with only primary services and mainly for immunization, and most of the time they don't receive any other kind of services. Next slide, please. And now we started, of course, after all of these discussions, agreement, capacity building, the community health workers, they started implementing household level interventions and the community level interventions, working on maternal, child health and nutrition topics, addressing different topics related to the health of the mother and child. Next slide. So what we did at the beginning, because we were not sure about the intervention and the acceptance by the ministry and the other partners, we did an operational research. So here this graph presents the results of the operational research that we did. If you look at the first part of the slide, you will see, for example, indicators such as exclusive breastfeeding. The first column is the intervention group and the second one is the comparison group. The first part of the graph is before the intervention, which is the baseline. So here we can see that before the intervention, only 27.3 were exclusively breastfeeding, whereas after the intervention, among the intervention group, it was increased to 68.7. The same for the other indicators. You can see the improvements. For example, most of mothers, they stopped using the bottle feeding. They focused more on breastfeeding. They continued on breastfeeding their children for above 1 year. They used to stop at 6 years, believing that it's enough for the baby. Next slide, please. And the same here for recognition of danger signs. We used to lose so many lives among mothers and children because they were not aware of the danger signs, and they couldn't make it on time to go to the hospital. But with the support from the community health workers and the referral that we have developed with the community health workers, they managed to introduce and they managed to work more closely with the mothers so as to recognize the danger signs and refer the mothers on time whenever they recognize any danger signs among the mother or her child. So this as well represents the achievements, and you can see the difference before the intervention and after the intervention. Next slide, please. And this as well represents another indicators related to diarrhea management, for example. And we used to have so many wrong behaviors during diarrhea, like stop breastfeeding, giving different kinds of herbal drinks. And after the intervention, community health workers, they work closely with the mother, introducing the right ways of addressing diarrhea and other, of course, health problems and issues among mothers and among their children. Those are only few examples. Of course, we have so many other data that reflects the achievements of the community health workers and the messages that they used to deliver to the mothers. Of course, it was more of a behavior change rather than just delivering messages. And they have delivered activity not only at the household level, but at the community level. And at a later stage, they started working with the ministry, supporting the ministry, and delivering so many activities as part of the services the ministry provides for the communities. Next slide, please. And what I want to focus on is that in addition to the great contribution and the significant positive contribution of the community health workers in addressing maternal mental health issue, also this programming, the community health worker, and introducing this programming actually supported a lot in addressing other great achievements. And now we will see the other great achievements that this kind of programming and having community health workers in communities doing their task helped in transforming their relationship, not only within the community members themselves, but also between members of different communities. So they started making relations with other communities. They started building and trusting relation at the household level. And now, like, the community health workers are becoming close friends with family members, not only like the mother, but also the father, the husband, and the mothers-in-law, because in our interventions, we as well included husbands and mothers-in-law, because they are sometimes the decision makers, and not including them may affect. And by doing this, like, we have overcome so many challenges, because like for people living in such communities, they are not allowed to talk to men. But through this kind of approach, like, we overcome this problem, and community health workers can easily go and discuss things with husbands in order to convince them for the benefit of their wives and children. A good thing is that it helped also in building good and positive relationship with neighbors, with relatives, who as well started coming and inviting themselves to attend the household visits. And this improved the relationship between communities and between members and between relatives in the communities. Next slide, please. Actually, one important point as well is related so much to the community health workers, and it's relating so much to changing communities' acceptance of working women. To be honest, before this intervention, females were not allowed to go outside their communities. They were not allowed to finish even their education. But after that, after they started and becoming part of this intervention, the community health workers becoming more recognized by the community members, by their parents, and they managed after that to finish their study. And now they are very highly respected community members. They are well known by all the community, and most of them, they managed to finish their education and to go to university and to go to the city to finish their education. The other thing is that community health workers, they started even changing themselves and how they deal with each other. So they started supporting each other, and sometimes if they have to go to other communities in case of the absence of one of the community health workers, so they as well overcome these challenges, because at the time when we started this programming, it wasn't allowed for the community health workers to leave their community, and it was almost impossible for them to go to other communities. But within this approach, they can now easily go, and they have this trust, and the communities, they do trust them, and so they can support each other when needed. The good thing is that one of the important things is the transformed relationship between the community members and the Ministry of Health. And because of that, like now the community health workers are trusted people in the communities, and they encourage mothers to go and receive services at the MOH clinics and mobile clinics. So that improved a lot the utilization of services provided by the Ministry of Health. And it was like mentioned in the reports, and the numbers increased significantly as per making this trustful relationship between communities, health workers, and Ministry of Health. Next slide, please. Another achievement that's related to introducing such a programming in Palestine is the positive effect of the community health workers in their personalities. Now they are well-recognized people, respected people. They have their voice. They become decision makers within their communities. People refer to them, to ask them, to seek their advice on many other issues. And now they become positive like models for the other females in the communities. Every day, like we receive calls from other community members saying that we would like to join you, we'd like to be like the community health worker in our community. We want to serve our community and become well recognized in our communities, and to see the impact on mothers and children's health, because to be honest, they managed to save the lives of many mothers and children. So they become like heroes in their communities, and they become the model that all other females want to become like them. Next slide, please. Nowadays, the community health workers that we have trained all around West Bank and Gaza, they perform a wide range of tasks, not only doing the household level activities, but as well conducting community awareness sessions, community campaigns. They are working now with the Ministry of Health. They are now doing the growth monitoring at their communities, the referral, of course, of urgent cases. And they were empowered to the level that they started writing scenarios on educational plays, and they performed these plays in different parts in Palestine. So they became like empowered to the extent that they started thinking of many other activities outside their communities and in a very innovative way. So it was like a great achievement, the play that they have wrote and the activities that they have implemented. It was really huge, and the impact was really huge. Next slide, please. Additional things that I want to add to this is, at that time when we started working with them, most of them, they used to say that their parents forced them like to marriage, and it's not their choice, but that changed a lot since introducing the program. Few of them, they became members in village councils, they became decision makers in their communities, and now they are registered at the Directorate of Health as community health workers, supporting the ministry and helping in strengthening the system through delivering services. And the point here is that we don't have like enough staff at the Ministry of Health. So having those community health workers supporting the nurse and supporting the doctor really made a huge change in their communities. Next slide, please. And finally, here are quotes, one from a community health worker and the other from a mother. So the community health worker saying, I wanted to be a community health worker because I always wanted to know the right information concerning topics related to mother and child health and nutrition, and I always wanted to transfer this to my community. And just to comment on this, they only receive incentives, and every time you ask them, are you going to continue working and continue delivering these services to your communities regardless of these incentives? They said, of course we will. We are serving our families, our sisters, like this community is our family, and we will not stop serving our communities and our families. And this is as well a quote from a mother She said that confusion is what I used to feel. Before this project, I used to hear different stories about infant care and feeding practices. But now I'm so happy. I'm not confused anymore. I have one source of information that I can rely on. And I really can see the impact of that on my child. This is a mother from Beit Lahem, one of the villages that we target. And recently, the community health workers, we started with them adding and building their capacity on psychosocial support and maternal health, as it is a major issue in our context. So they will be trained on psychosocial support and maternal health. And now they have the smartphones. They will use the smartphones to collect all the ministering data as part of the activities that they deliver at their community. Thank you.
Thank you so much, Hannah. That's a fantastic presentation, presenting how the program started, the challenges faced, the tremendous gains in health outcomes, but then evaluating more closely the effects. How did those, what was underlying those gains in health outcomes in terms of the linkages that these community health workers were able to have at the household level, having an intimate understanding of their communities, but also looking at the transformation at the personal level in terms of planting these seeds of change. I'm going to just, we are at 8:50, we have about 8 minutes left in the webinar, so I'm just going to make two overarching reflections, and then there are two questions linked to those reflections that I'd like to pose to the panelists. And we might go a little bit over, but I want to give an opportunity for there to be a discussion on these issues. The first thing I wanted to flag was really the evidence base in this, and it's fantastic that Sally is doing an updated review on gender and their group is doing an updated review. Ruth Simmons, in my previous review, did one of the first studies in Bangladesh in 1992. And I want to recognize the role of Zubia Mumtaz in 2003, writing about lady health workers, and Karen Daniels in South Africa talking about lay health workers. It's taken us 10, 15 years, but I'm so glad that this is finally on the agenda, and we need to build the evidence base, make it much stronger. The percentage statistic that Sally quoted, that 70% of community health workers are female, that's drawn from only the subset of 17 studies in a broader review that had disaggregated data by sex. One of the challenges in highlighting the gender issues is people simply don't even disaggregate by sex, so we make a lot of assumptions. A review of CCM programs showed that in those programs that targeted sick children, most programs had mixed community health workers, both male and female, and that's one of the also comments from the panelists. So I think we need to really build the evidence base in this area. And it's not just gender, but how gender combines with age. And I think this is really becoming a high priority issue. Many countries are formalizing their community health worker program. And we were going to include, unfortunately, Stelio Demande from the Ministry of Health in Mozambique wasn't able to join us. He was going to share reflections after upgrading the community health worker program and making it into a semi-paid cadre. What have been the challenges in terms of gender, in terms of attrition? It is a move that Tanzania has made, Burkina Faso, and some of the implications have meant that older women in the community that maybe had more acceptability for talking on maternal child health issues don't have the education and are not being can't be included in the policy. So these are unintended consequences. I want to pose two questions coming from that. Audience members really wanted to know more about a lot of programs focus on maternal and child health and have female community health workers. But if we really want to address gender issues, we also need to include men and other stakeholders. What have been your experience in, are there guidelines or your experience in how to select community health workers? Keep in mind that to balance out this male to female ratio. And another comment is, as these policies upgrade, is it fair that a lot of volunteer programs are predominantly women? And is it because they're women that we think it's okay that they can be volunteer? So if we could have some quick comments from the panelists on these two issues. How are your experiences of male and female community health workers working together? What programs have done about that? And the issue of volunteerism and having primarily female cadres volunteer.
Shall I start?
Sure, Hannah, go ahead.
Okay. So in regards to the first point, in our context, it's not acceptable to have male as a community health workers, because most of the time community health workers, they address like critical issues mainly related to women, such as breastfeeding, and they have to deliver sometimes most of the activities at the household level. In our context, most of the activities we do at the household level. That's why for male it's not acceptable. And for the other, like having volunteers, as I mentioned, men usually they go outside and they work in things, but not to be like as a community health workers. And for females, this is acceptable because they are working within their communities, so it's something acceptable. And the incentives they take, it's like fair enough for a woman working in her area. She doesn't have to leave her children, and she can be close to her family and house. So this is the situation in our country, but of course in other parts of the world, I think the situation is different.
Thank you so much, Hannah, for sharing. Amuda, do you have any reflections from the context of DRC?
Yes, I think the problem of male and female, this is a big topic which needs to be seen in the context of cultural background, because there are some spaces which, where culture is really a driving element, and there are some specific issues so far in some areas where a male will not be very stable to discuss with the lady, especially if the male is a community health worker. So I think all these issues need to be, of course, taken into account. But why do we have normally many women? And in the context of rural Congo, as in many African countries, the voluntary aspect of the work, they feel in the context of my country, they usually say, going around raising awareness, talking about health issues within the community. This is a women's work, and that's what everyone says. So if they see a man coming out and shouting and raising people's awareness, they think something is going wrong. I think that there is a need to see how to address this issue, but taking into account the cultural background behind it. And the other challenge for men, most of them can have a job opportunity, but once there is a job opportunity, they are tempted to leave, to go, but women are there permanently within the community, and they really make you sacrifice for the community. That could be another cultural context explanation on this issue, but I think, as you mentioned, we need some evidence-based elements to focus on that.
Thank you so much, Amuda. That's very helpful in understanding those dynamics. Sally, do you have any last concluding thoughts?
Sure. So I think great inputs from Amuda and Hannah, which reflect what I said earlier in terms of gender roles and relations are shaped by context. And certainly we've heard, in DRC that women would prefer to talk about fistula with a woman CTC provider. In context in Kenya, men have said they'd sooner have HIV testing with a male provider. I think gender matters. I don't think there's enough discussion on that in terms of guidelines or policy. I think, as you said, Asha, we need strategies to engage male community health workers as well as women. We need supportive supervision so community health workers can share and be supported in the decisions and dilemmas that they have. So, for example, for women community health workers, engaging men in sexual and reproductive and maternal health. So I think that's important to have those spaces. Kate Zelenko, so I can also see the comments has been saying, is it about the fact that they're mainly women, that they're mainly voluntary in some contexts? And certainly I think there is a worrying idea that women's labour is infinitely elastic and isn't always necessarily remunerated appropriately. I think we need to keep discussing that. And just a very quick comment on the question from Khalifa Al-Musharraf from the University of Limerick, which is around what is the position of TBAs within the new paradigm of close-to-community CTC providers. And I think what we've seen in our work in Reach Out is that close-to-community providers are building alliances in some places with TBAs who also have those trusting embedded relationships. But again, that can be challenging in contexts where TBAs are legal or not legal or frowned upon. In Sierra Leone, we saw TBAs being retrained and almost relabeled as maternal health promoters to support the referral of women to health facilities. So I think that's an interesting area, those linkages between two different groups that needs further discussion. Thank you.
Thank you so much. There's now a avalanche of monsoon of comments and questions, and what we'll do is continue some of this dialogue through the thematic working group on community health workers. I think it's been really valuable to see the feedback from so many participants, as well as to share the experiences from both DRC, the West Bank and Gaza, as well as Sally's overview and experience in multiple countries as well. One question I think it's very important to flag is really looking at, we measure often the health outcomes, the impact of community health workers, but really putting on the agenda, measuring what Hannah was talking about, also assessing what do these programs, and Karen Daniels had done this earlier, mean for the women themselves that are involved in these programs. And I'm not sure we've done a good enough job in actually measuring that, and also seeing how can gender, changing gender norms be part of the roles and responsibilities of both male and female community health workers, so that we don't silo. Even maternal and child health has really important gender issues that need the engagement of men. And so how do we assess better that integration of materials so that they're better supported in this area, and then evaluate the outcomes. So we're going to close from now, not from lack of interest, but just out of lack of time. But we hope to continue the conversation, both through the thematic working group, as well as through all our different partnerships with Reach Out, but also with RINGS. It's a partnership that's really trying to increase attention to gender in health systems. So we look forward to continuing the discussion, and hopefully many more abstracts in Vancouver, so we can take the discussion, highlight more in the month of March to celebrate International Women's Day, but also continue the discussion throughout this year and meet in Vancouver as well. So I'm going to close for now. We're going to have a few evaluation questions, and I really want to thank all the panelists, Hannah, Amuda, and Sally, for their excellent presentations, for speaking so passionately, and look forward to more in advancing this agenda. Thank you.
Thank you.
Thank you.